So moving on to the last session before lunch, and this is going to be really interesting. It's a clinical case discussion, clinico-pathological discussion basically. So I would like to invite on stage our chairperson, Dr. Madhusudhanan, who needs no introduction. He's a professor and head of neurology of Travancore Medical College, Ernakulam. Dr. Vijay Sardana, who is the senior professor and head of Department of Government Medical College, Kota, who has special interest in cluster headache, Alzheimer's and PD. So I would request our chairpersons to introduce our speakers.
Hello. Good afternoon. CPC's clinico-pathological sessions have long been a way of good learning, good way of making good reasoning and critical thinking. And today's session, I think, is going to be such a session. I request first Dr. Lakshmi, who will discuss the case and present the case, and then we can have short discussion, and then pathological discussion will take place. Dr. Lakshmi.
Yes. Good afternoon, everybody. At the outset, my hearty thanks to Dr. Arun Gag for inviting me, and all his kindness and hospitality. I am grateful to you. Thank you. And secondly, I am delighted to talk in front of the greatest clinician, Professor Madhusudhanan, who is my mentor, my guide, and so many ways is my inspiration in clinical neurology. I'm proud to be talking in front of him along with my very good friend Vijay Sardana from Kota. So with this, I just wanted to take you to what was the data given to me by the pathologists. Pathologists are always very stingy in giving very minimal details to the clinician. As always, they want to win the battle. And it's always in CPC, the battle between the clinician and the pathologist is on and on and on. And we as clinicians, we are not bothered about the result. But whatever data she has given me, I'll just read out. A 64-year-old patient, known case of hypertension, CAD with special precaution of PTCA, now presented with giddiness associated with nausea and occasional memory disturbances for 1 month. Apparently asymptomatic 1 month back, when he developed dizziness, apparently normal, 1 month back when he developed dizziness, associated with nausea, not associated with postural variation, mild in intensity and used to occur while both walking and on rest. History of headache since 1 month, holocranial, dull aching type, mild in intensity, not associated with any postural or diurnal variation. The vomiting, which is for 3 days, 1 month back, non-projectile, associated with nausea, subsided after stopping Ultracet tablet, which was used for the pain. Patient relatives also noticed that he developed memory disturbances, forgetting what he had for breakfast. Also, after doing prayers, he used to forget that he has not prayed and does prayer again. He also forgets keeping things at same places and also not able to recall where he kept them. No history of aggressive behavior or hallucinations, no history of abnormal behavior during sleep, no history of weakness of the limbs, no history of any speech disturbances, diplopia, closing eyes, no bowel bladder, no history of any other cranial nerve involvement, no history of trauma, seizures, syncopal attacks, and other headache, no history of fever, cough, cold, and any recent vaccinations, herbal medicine intake. Past history, known case of hypertension on regular treatment, known case of CAD, no history of CKD, CVA, or TB, epilepsy, or thyroid, no history of similar complaints in the past, family history is not significant, personal history, mixed diet, sleep normal, appetite normal, non-smoker, bowel and bladder, regular habits. So this is what the data given to me. You know how stingy they are. And so anyhow, first complaint is the dizziness. And dizziness is a very vague term. And the Baranis, and it was not associated with postural changes, not associated with feeling of nausea, and it is lasted for a month. So therefore, the Berenice Society classifies 4 types of dizziness: vertigo, disequilibrium, lightheadedness, and pre-syncope. Why I bring this is, this patient is a known case of CAD operated with PTCA, it not necessarily to be so. I thought, what are the dizziness could be central, likely because it is associated with headache, continuous without any postural variations. Autologic is less likely, not associated with postural changes. Medical causes, cardiac causes possible. And non-specific post-traumatic malignant anxiety is unlikely. So I thought the 2 possibilities is, one is medical, and then if you really look at the possible sites of involvement of the dizziness as taking vestibular, higher vestibular things, semicircular canals less likely because there is no postural variation or aggravation with head movements. Brainstem and vestibular nuclei possible. Cerebellum less likely, no other cerebellar signs. Parieto-insulovestibular cortex possible because this patient also had higher mental function disturbances. So I thought for the dizziness I would take a central cause. So this is what is likely. Then I would go to cerebellum is unlikely. So what could be the central causes of vertigo? It could be neoplastic, old age, or subacute. It can be it's possible. Inflammatory is possible, demyelination, sarcoid, IgG4, and all these things. Toxin exposure, there's no history suggestive of that. And subacute infectious causes, TB, cryptococcus, fungal, those things can also produce these higher causes of vertigo. Vomiting lasted for 3 days and non-projectile, associated with tramadol intake and subsided after tramadol. Okay. If you take the vomiting inputs can be cerebral inputs, the vestibular inputs, from the area postrema or the afferent from the vagal. All possible can produce all these things produce inputs to the nucleus tractus solitarius, and it projects to various other outputs, salivatory nucleus, the ventrolateral medulla, and all these things. You can see what all the nausea, cold sweating, salivation, all these things are possible in the vomiting construct. But if you really look at the variety of inputs, integration the inputs in the nucleus tractus solitarius, and output salivary nucleus producing salivation, vasomotor producing vasoconstriction, dorsal motor nucleus of vagus producing the retrograde contraction and ejection of the gastric contents and respiratory groups. So what I thought, all these things is theory, but our patient is temporal association with tramadol, stopping tramadol, it lasted, there is no other signs of ICT, so I just leave that vomiting at that point of time and move on. So next, coming to the headache. Patient has 1 month holocranial, dull aching, mild intensity headache. You look at the pain sensitive structures in the skull, the scalp, the parts of the dura, the arteries, the meninges in the larger arteries, great venous sinuses, pain sensitive fibers in the trigeminal system, 9th, 10th canalus, and head and neck muscles. So you are applying the Snoop criteria of whether it is a primary or a secondary headache. Patient had secondary risk factors like CAD. Patient other neurological signs and symptoms. Age older than 50. All these things make that headache possibly a secondary headache instead of a primary headache. So I go in for that. So with this, patient in question has probably a secondary headache. So coming to the next examination of the higher functions, and Professor Madhu during his discussion might highlight you more because he's the doyen of higher functions, and orientation to time, place, person was lost in this patient. Looking at what is the cause for likely network involved in this is the default mode network. The default mode network involves these various hubs. And if you look at this, I'll draw your attention here. Okay, let's go back. The default mode network identified in a separate resting scan was active in all orientation domains, overlapped with person orientation designs, finally suggesting that Mental orientation in space, time, and person is managed by a specific brain system, highly ordered, closely related to the default mode network. So our patient had disorientation to time, place, and person, probably involvement of the, and executive functions were impaired. No planning. Patient had likely network is the dorsolateral prefrontal cortex and disconnections, dorsolateral caudate nucleus, lateromedial dorsal nucleus, and thalamus in the ventral. Memory disturbances. Forgot what he had for breakfast, repeats prayers multiple times, forgets where he plays, 1 month duration, progressive. So types of memory, as you know, that episodic, procedural, associative, non-associative. See, our patients forgets events pertaining to him, so the type of memory affected is episodic. And here, the one more thing, he forgets where he plays the things. So the visuospatial, this implies a defect in the visuospatial sketch pad, which is part of the working memory that retains the visuospatial case per 2 components, visual and spatial. The words are in the phonological loop. The other part is the visuospatial sketch pad. And the visuospatial memory impairment or the visuospatial sketch pad, the studies on the brain damage have demonstrated that the lateral prefrontal cortex and essentially in the right parietal cortex, I have underlined that, and the right temporoparietal cortex junction. So that is the place where the visuospatial memory is predominantly located and damage anywhere there. So this is the pictorial representation of the visuospatial memory impairment with its various. Broca's with its loop, parietal lobe with the episodic buffer, and the ACC, anterior cingulate cortex with the attention controller, and the central executive, the occipital lobe where the visuospatial sketch pad. So our patient had immediate working memory, episodic memory, or the two things which are the short-term episodic memory, the medial temporal lobe was involved, both immediate and short-term memory impairment in a month. So causes of episodic memory, as all of you know about the Pepper circuit, I don't want to go into the details. So to summarize whatever the little data which is given, memory disturbances with the medial forebrain structures, visuospatial, right parietal and the posterior cingulum visuospatial network, and headache, irritation of the meningeal structures, dizziness, parieto-incipito-vestibular cortex is likely, and vomiting, which I have discarded, the drug-induced tramadol. So this is what, in essence, in the clinical data, what she has given. So I have the structures which I have localized based on this. Temporal lobe, dorsolateral prefrontal, right parietal lobe, and the posterior cingulate cortex. Etiology could be infection, inflammation, tumors in a subacute onset, about a month duration. So we go on to the neuroimaging, which was done twice in 15 days gap, 7/6/21.
What about the findings in this patient?
Findings, you have that?
No, just one thing.
Yeah, you can
No,
read
that part, that you are not.
I'll read it.
No, okay, you can read that one.
The patient conscious, disoriented to time, place, and person, no pallor, icterus. The vitals are normal. The CNS, not oriented to time, place, and person. GCS is 15/15, speech is good, language is normal. MoCA 15/30. Deficits in the executive function, visuospatial and memory function. Cranial nerves, pupils, bilateral normal. Visual acuity normal. Visual fields normal. EOM full in all directions. Saccades pursuits normal. Convergence normal. No facial palsy, no hearing impairment. Uvula normal. Central, other cranial nerves normal. Motor system is essentially normal. And all other things normal, except there is in the reflexes, there is an involvement of the triceps is sluggish on the right side, triceps supinator and ankle are sluggish on the left side, triceps supinator and ankle is sluggish, plantar flexor, sensory examination is normal, frontal release signs negative, cerebellum normal, all the cerebellar functions normal, skull and spine normal, no neurocutaneous markers. These are the findings. Okay. So most of the blood parameters did not contribute much. So for want of time, I am straight away moving on to the MRI images which was provided to me.
There's one point here, the CSF cells is 10 cells it is written. Just one more point.
Clinically, we'll finish it. They want clinical.
Sir, clinically, what is
No,
the
no.
possible
First,
diagnosis?
let us
before we
discuss
before we get the
clinically-
investigations. Okay,
Yes.
okay.
Clinically, what is a, we can have opinion
Impression.
of the crowd that what is a possible diagnosis with?
Okay, okay.
Can you just
you
go
did
back to that
mention
history first?
possibilities, inflammatory
Yeah,
SOLs,
no,
and
so
can you
let me-
elaborate a little
Lakshmi,
more on
what do
that?
you think clinically after
Well,
examination?
I thought it's I've got the last one. The structural localization is the right parietal, posterior cingulate, temporal lobe, and the dorsal. Etiologically, it could be a infection, inflammation, and tumors will be considered at this stage.
So that is his opinion. So anyone from the audience would like to make a comment or regarding localization or like the etiology?
The information given is very limited, so I didn't want to
yeah.
overstretch myself.
So in short, what we are dealing with is a rapidly progressing dementia affecting predominantly temporal lobe as well as the frontal lobes. So what are the things we have to keep in mind into this context? Obviously, it is not a primary dementia. So you have to think of secondary causes like tumors, inflammatory conditions, autoimmune encephalitis, or other subacute encephalitis like CJD. Even subacute meningitis you have to keep in mind, and CNS vasculitis. I think that also has to be included under this. They can all present like rapidly progressive dementia conditions. So I think upper hand will be a tumor or an autoimmune encephalitis. That will be my way of thinking clinically. So what do you think?
I think that's the right thing. Broadly, we cannot pinpoint at this point.
Yeah, at this point of time.
Anybody wants to add anything on this at this point of time? Yes? Anybody on the floor wants to add any other point? Thank you. Then we move on.
We'll move on. Okay.
This is the first scan done on 7/6/21.
I think, no, Lakshmi, first, other investigations.
Other investigation, I'll read that. Hemoglobin 15.9, PCV 47.8, total count 9,800, platelet is 2.4 lakhs, blood urea 23, creatinine is 0.83, sodium 141, potassium 4.8, chloride 98, LDH 236, PTANR normal, APTT normal, ESR 5, random blood sugar 119, SGOT, SGPT normal, ALP normal, bilirubin 0.7, 0.14 is conjugated, and TSP 7.7, albumin 4.3, calcium 9.7, ACE is 31.34, HIV, HB surface antigen, HCV non-reactive, complete urine examination, not normal. CSF analysis, 10 cells, WBC 10 cells per millimeter, lymphocytes, all lymphocytes, glucose 61, 64, protein 58, AFB negative, fungal KOH negative, malignant cells absent, cryptococcal negative. Nerve conductions findings suggestive of right carpal tunnel, VEP is normal. Then imaging.
So basically, to summarize, only abnormality is a little blood sugar 190 and CSF abnormalities. ACE is normal, ESR is normal, rest everything is normal.
Blood sugar is 119, and CSF has shown mild pleocytosis, all lymphocytes with a mild elevation
Little
of proteins,
protein.
and that's all. So anything, those
And one NCS finding, I think you have. NCS one, carpal tunnel. Okay. Carpal tunnel syndrome, nerve conduction study shows.
So there is a small T2 hypertension lesion in that place, and then you can see a T2 weighted images showing hyperintense lesion in the medulla with no contrast enhancement. And this, you can see that this is the right trigonal area is the lesion, which is, you can see this. Contrast enhancement was seen in the right peritrigonal area in a patchy manner. So this was the lesion. And then it was repeated at 18/6/21. You can see this is and you can see the edema around the thing is extensive. T2 weighted well-defined lesion, the peridiagonal having a thick capsule. You can see this. You can see that this is a thick capsule. You can see that. And you can see that there is a small, you can see that there is a small, like a cortical ribbon sign you can see on the medial aspect of the floor, and sulcal pattern of linear hyperintensity T1 imaging, probably post-biopsy bleed or cortical lamina necrosis. I will come to you, show you why it's. And another important thing is T1 contrast sagittal image. You can see an enhancement of the infundibular region in the pituitary stalk and a prepontine meningeal enhancement. So these were there. So if you look at T1 hyperintensity, it could be methemoglobin, fatty products like cortical laminonecrosis dermatosis, or mineral deposition like manganese iron, or protein-rich example crenif. These are the things which appear in T1 hyperintense. So going back to this is the T1 contrast. So what are the possible things are cortical laminonecrosis, dermoid, and a blood product. So it looks like more of a. So lesion hyperintense on T1 it is cortical laminonecrosis and the blood products. In this case, what I thought was, since they had done a biopsy and that whatever the sulcal hyperintensity could be due to a blood product. That's what I thought instead of a cortical. The strong possibility, there's no history of seizures, hypoxia, so post-biopsy bleed is more likely. And this is the sagittal section. You can see the lesion and T2 weighted images showing a peritrigonal which is hyperintense on T2. Extensive edema, the capsule is hypointense and the edema is extending into the corpus callosum, and in fact it's bilateral. You can see it's such an extensive on both sides is the edema. No, they have not provided me that. They have not provided me diffusion weighted. Spectroscopy of that. Yeah, I'm coming there. Spectroscopy they have given me. And you can see that there is a biopsy track, and probably the diagnostic investigation which they performed is a stereotactic biopsy. I could see a skull defect there and a linear track biopsy tract that is seen in the T2. Probably, I don't know, the pathologist. Where is madam? Megha? Yeah, I'll go there.
Let me finish.
We will just one more. I'll finish.
Let me finish his interpretation, then come back.
I'll finish out a couple of more images and then leave it to you. Meningeal enhancement noted in the arrow. Second image is shown the ring enhancement of the lesion. The contrast enhancement pattern is different from the first MRI, which is more of a patchy. And they have done a PET. You can see the PET, the area in the right peritrigonal area lights up, and what I can see is, you can see a small, I've taken the one right parotid, there is a lighting up on the right parotid gland, and a small node in the anterior mediastinum near to the thymus. They're difficult to tell if it's embedded in the thymus or it's just a anterior mediastinal node. PET positive lesions, anterior mediastinum, left parotid. Mediastinal lesions may invoke the possibility of thymus. So this is the MR spectroscopy, sir. MR spectroscopy over the lesion, preserved NAA with a lactate peak. Perilesional area showed a decrease in the significant choline peak, double lactate peak suggestive of an anaerobic metabolism. So this is what the MR spectroscopy. So anything else, sir? Anybody else? So what I thought I'll finish off what I think and then leave the discussion.
Let me finish off your interpretation and possible diagnosis. Then I'll open the house for their opinion.
I'll finish off that.
Yeah, finish off your different diagnosis.
I'll finish off the. So, any lesion, the trigonal could be demyelination, lymphoma, or infections or inflammatory. Is a common 4 lesions in the trigonal, peritrigonal area. I'll try to do the clinico-radiological correlation. The sarcoid has a predilection to take the vestibular system. In total, not only the vestibular nerve, it has a higher predilection. Lot of case reports are there, and where the dizziness is one of the presentation of a neurosarcoid. Normal serum AZ levels in the absence of lung involvement and non-improvement of or points again. But anyhow, neurosarcoids with vertigo is not uncommon. Brainstem involvement, parotid gland involvement, carpal tunnel syndrome are also points favoring the sarcoid. And as a criteria, it would, it has involved the parenchyma, it has shown meningeal enhancement, it has shown one parotid gland, it has shown vestibular involvement, it has shown the carpal tunnel, And so I thought that is one of the points for and against sarcoid was subacute course with focal deficits, meningeal involvement, suspicious pituitary stalk is again, a suspicious pituitary stalk involvement is again in favor of sarcoid. T1 hyperintensity and T2 hyperintensity lesion, leptomeningeal enhancement, parotid gland, and the vestibular system involvement are points for neurosarcoid. And points against any other cranial nerve involvement like facial, worsening after steroid. The patient worsened after steroid, and the choline peak is a very strong negative point against the then. So tumefactive demyelination, extensive edema, which and inflammatory, I have said already told you, and lymphoma and infections. So if you really look at the non-improvement of steroids makes tumefactive demyelination unlikely, plus infections have to be ruled out before considering tumefactive demyelination. Fungal, a few fungals can present as granulomatous lesion like this with extensive edema, aspergillus and Cryptococcus. But the MRI pictures are not classical. Points for tropical climate, subacute dementia with meningoencephalitis, and points against are no underlying features, and the CSF has not thrown any clues, and absence of sinusitis or any other things, and systemic manifestations are also fairly very less. Opportunity fungal, that Cryptococcus named Candida and Aspergillus and zygomatis, fungal meningitis, acute fungal meningitis can also present as subacute dementia. And then does not help, pleocytosis does not help in further narrowing down the lesions. All the diseases can produce the CSF pleocytosis. Protein is only 58, non-specific and above still expected high protein. I'm just coming near. CSF granulomatous diseases, bacteria, spirochetal, tuberculous, fungal, inflammatory. So rare presentation is common. So CNS, whether it's just tuberculosis, point in patient being started on ATT worsened with steroids, but could it be a TB iris? But I felt with CSF non-contributory, I thought it is unlikely. Lymphoma, the presence of parotid gland lesion, mediastinal lymphadenopathy, non-improvement with steroids, documented lymphoma, presence of choline pack is also in favor of a lymphoma. T-cell lymphomas can involve thymus and can present as a granulomatous lesion. So the clinical or for patients for and against parotid enlargement, mediastinal node, patchy enhancement of the leptomeninges, the MRI which disappeared after steroids, choline peak, clinical worsening after steroids is against, not very confident, systemic except parotid, but this may occur. Coming to whether what is a primary CNS lymphoma or a systemic lymphoma with secondary involvement of the brain. And I was most often the meningeal involvement is, Sir said it could happen, but the meningeal involvement is slightly on the lesser aspect in primary CNS lymphomas. And secondly, it cannot explain the mediastinal, anterior mediastinal node. Primary CNS lymphoma, you can't explain the one anterior mediastinal node and a parotid involvement. So that is where then. So this is the differentiation between primary CNS lymphoma and leptomeningeal involvement is very more common, 2/3 involvement in secondary CNS lymphoma. And MRI findings, T1 hypo and T1 iso intense and T2 hypo intense. And in favor of secondary CNS lymphoma than primary. Malignant lymphoma is one of the possible underlying causes of granuloma. Granuloma may occur in various types of, and T-cell, NHL and Hodgkin's lymphoma are notorious for masquerading like granulomas. So my possibilities, I considered IgG4, which can involve parotid, but the lesions in the parotid are not classical granulomas. But that can also have a granuloma in the granulomatous lesions in the brain, the IgG4. And most of the, but I would stick on to sarcoid and a lymphoma, one of the two. Thank you.
Lakshmi, you have given a very wonderful.
And one more thing, sir, which I saw, that image which we are not able to. This one of these images, one of the images in the trigone, in the contrast, the vessels were still persisting along the. They were not obliterated. But when infiltrations, invariably the veins will collapse, which was not there, which was present, and Sir would highlight on that.
In fact, Lakshmi had sent me the films. So I had an opportunity to go through the case as well as the films earlier. One of the pictures showed, the contrast film showed that even those areas which is enhancing, that is the peritrigonal area, the perimedullary veins are seen clearly going through that lesion. So in fact, seeing the case, I consider two possibilities. One is lymphoma. Second possibility was seeing that if I was wondering if it is a mass lesion, why the veins are not distorted. So I am keeping the possibility of something like an autoimmune encephalitis, like a GFAP, encephalitis is one possibility which I had kept in mind. So this is the two things I had in mind. So I think you have got any opinion before I open the...
I think if we take parotid involvement and the brain involvement together, three, four things comes to mind. One is tuberculosis, of course, most common, sarcoidosis. Vaginous granulomatosis is one thing which can involve rarely parotid and brain. And of course, the rare IgG4 and granulomatosis with polyangiitis is another diagnosis, very rare, can involve parotid and brain. But I think if you have the granuloma, then you can further limit your diagnosis. If the radiological opinion is in favor of granuloma, then of course sarcoidosis will be in the forefront with the differential of lymphoma.
One MRI peculiar finding here, if you have seen that, the lesion is all surrounding the ventricles, not only in the posterior part but also in the anterior part. But only the area which is enhancing is the peritrigonal one. I think I'll open the discussion for the House. Anyone who would like to make their opinion, comments, diagnosis,
So
please.
before opening that, I just wanted to say that, so as far as the panels is concerned, we have put on the diagnosis on the sarcoid and lymphoma. The autoimmune encephalitis with the GFAP is one of the possibilities Professor Madhusudhanan sir said, and the fungal and tuberculosis is still right on the cards. So these were the few of the differentials which the panel has decided.
Yes,
and now
Dr.
it's
Rohit,
open to the floor.
Yes, Dr. Thomas.
So man, 68 year. Initially, when you presented, I think nausea was there, no? You had headache and nausea, and then giddiness. Giddiness is a very significant symptom which is going on for 1 month, right?
Temporal relationship with ultraset, the vomiting and nausea. Giddiness was there first. That's the first symptom.
It initially thought like an area postrema presentation, like nausea, little giddiness going on. So about at the age of 68, if you think from that level with the MRI, usually it is a secondary area postrema, like aquaporin, secondary aquaporin. So paraneoplastic.
Can you hold the mic a little more closer?
Yeah. So it can be more of a paraneoplastic aquaporin related syndrome like area postrema. If you think about the lesion in the medulla, and there may be, so have you done a paraneoplastic antibody like anti-CR, anti-CV2 antibody, collapsing response and mediated? We have not done any antibody. MOG and aquaporin? We have not done that. So if you think like that, if it is an area postrema syndrome at this age, it is more only paraneoplastic, either secondary by lymphoma
medulla and periventricular lesions. That could be a secondary aquaporin and possibly a paraneoplastic.
Yes.
Fair enough.
Yeah, please, Rohit.
Yes.
Rohit, yeah.
So, the broader picture is that this is a...
Can you be a little more louder so that you can take the mask for a time being?
Sorry, sir. The broader picture is that this is a gentleman who's 70 plus,
64.
60 plus, and has a rapidly progressive cognitive disease. So the broader picture is that it is a gentleman who's presenting with cognitive disorder as his dominant clinical feature with such widespread brain lesions. So I think and those lesions are posterior dominant with anterior involvement, and the primary lesion is not enhancing. This lesion itself is not enhancing.
No, that area is enhancing, peritrigonal area.
In the contrast scan, the lesion itself is not showing any brilliant enhancement.
No, Rohit, that area which is adjoining the period, that area alone is enhancing.
Small area, sir. Very small area relative to the whole lesion. It is probably 1% of the whole 100% lesion.
Yes.
The lesion is not enhancing. It's just a small boundary of it which is enhancing.
Whether
That's one.
It's
Number
two. Part of the lesion is enhancing, that's all.
The parotid is a very, flimsy ground to base your whole decision, because At this age, with small parotid, old inflammation, some parotitis, this is seen not infrequently in PET scans. Number 3, sir mentioned about the small mediastinal enhancement as well. The question here is at 64 with these posterior based large lesions, lymphoma, of course, as sir rightly said, we'll consider these lesions. Everyone will always think of demyelination. Hair nahi hai. At 64 years, this is not the age for demyelination in routine. That we all know it. No one spoke about PML at all. Among the infectious causes, a 64-year-old, progressive cognitive decline, posterior periventricular lesions, non-dominantly enhancing, and we don't have a diffusion MRI. So is there a diffusion MRI finding available in this patient?
It's not given to me.
That should have been given because you cannot have a diffusion and interpret the scan, especially with lesions which are posterior dominant in an elderly male.
No, Rohit, you want to say PML?
I'm saying in this lesion, from inflammatory, from possibility of infectious, this distribution after lymphoma, also a possibility of PML can be kept. I'm just saying that.
Agreed with you. No, but only thing is I personally don't think it is PML because here the lesion is periventricular. Usually the PML lesions are subcortical involving into the subcortical E fibers. That is the location in the PML. Here is exactly surrounding the ventricle. That is not very common with PML.
It's posterior dominant, sir. It's posterior dominant.
Yeah, that posterior dominant is what surrounds the ventricle.
Lymphoma will remain, but chief of the lesion is not enhancing, but other features are obviously favoring. We all will
We keep that possibility also. Okay, anyone else would like to meet? Yes. Pardon?
Tuberculoma.
Because even if spectroscopy or the lymph node is also supportive, CSF may be normal.
No, the
In
thing
most
is
of the cases, it's normal.
that the MRI picture surrounding the ventricle like that, that's not the one you usually see in tuberculoma.
Sir, tuberculoma
And
may have
there's
very
no,
varied
and as you said, that only one part of the lesion is enhancing, the other lesion is not enhancing.
ESR is 5
Yes. But then with
and a
tuberculoma
colon
is
peak,
possible.
and a colon peak is there on the.
Sir, Satish Chandra would like to begin. Yeah.
64-year-old man presenting with rapidly progressive cognitive impairment with edema in the brain and raised tension symptoms, we would consider lymphoma as a possibility. Whether it is primary CNS lymphoma still is possible. So one need to keep that in mind. And ton cells in the CSF with meningeal involvement and some enhancement, I think lymphoma is a
Yeah, that's the thing.
Yeah, Dr. Lakshmi, how much important is this clue of carpal tunnel syndrome electrophysiologically and
think that's
subtle evidence of diminished reflexes, you think?
In fact, the sarcoidosis is one of the very common cause of the carpal tunnel syndrome. It's what the frequency of among the granulomatous lesions which can present as carpal tunnel syndrome, sarcoid is one of the leading cause. So I wouldn't, because that there's only one added collaborative point which I took that in my favor, but not this has got nothing to do with.
Yeah, correct. Yeah, please. Yeah. Yeah, more likely incident.
Yeah,
Yeah,
incident.
everyone has
But I took it for because there are enough reports of sarcoid presenting as CTS.
Yes, sir. In imaging, there are certain imaging sequences which would have been given like diffusion, SWI, because the presence of blooming microbleeds would have differentiated vasculitis from
SWI
lymphoma.
was given. It was no blooming was there.
So the lymphoma, the one lymphoma which do not enhances or partially enhances is the intravascular lymphoma or lymphomatosis cerebri. Usually the secondary lymphoma show restricted diffusion, they are solid. And lymphomas do have the periventricular predilection extending along the ependymal lining. And here the corpus callosum looked bulky. I don't know what happened to that, whether it was enhancing or not.
That's why I favored a lymphoma.
Yeah.
And as I told you, because the pathologist, and at least madam is more than Dr. Anita used to be even more stingy in giving the data. And I think madam is more liberal in giving me some more data. It's very little data. They always want to win the show.
Yeah, the perivascular, what you were saying, sir, peritrigonal vascular enhancement, that would also favor intravascular lymphoma over the secondary lymphoma.
I don't know.
All sequences would have been very useful to narrow down that.
Thank you.
The only thing look at the bigger picture of intravascular lymphomas, they generally present at step-up findings. They present with step-up deficits, one after the other, and mimic stroke-like episodes. This gentleman within 4 weeks is completely cognitively impaired. So lymphoma obviously stays as the dominant possibility based on this imaging. No doubt about it. All of us agree. This looks more like a usual lymphoma, if at all.
Okay, if there are no comments, any other comment?
And I think we'll call the pathologist for the final.
Yeah. Please, Megha, please. Before that, I would like to congratulate Lakshmi for his excellent way he analyzed the symptomatology and discussed the various different diagnoses. A big applause to Dr. Lakshmi.
Thanks, Dr. Lakshmi. That was a wonderful presentation and solving the case. I just wanted to tell you that I'm not being stingy. I have given you everything that was available with me. And that's exactly what was available with us. Nothing more than that was done for the patient. And we usually call neurologists stingy because we are looking at a CPC case and we still have a lot of information. Believe me, when I look at a case in practice, then I have nothing more than one word written on the form. So it's not we who are stingy, it's you who are stingy. So, she wants to make an announcement.
Yeah, so there is an announcement. All the delegates who are participating for the quiz, it's going to start at 2 p.m. sharp. It'll be from 2 to 2:45. So they are requested to have lunch before or after.
More than 15 minutes.
So lunch will be available till 3:30 in the pre-exhibition area outside this hall. So you are requested to have lunch before the quiz or after the quiz in order to be free for the quiz. Thank you.
Okay, so this is not moving further. The screen is not moving further. Yes, so that's where we begin, right? The first investigation of choice, or I should say an invasive investigation of choice in this patient was the parotid FNAC, because the parotid lighted up on PET and they thought that it's worthwhile doing an FNAC from that lesion. And there you can see on the slide, we saw 2 granulomas. Now what you are seeing are clusters of epithelioid cell there, and this in definition of pathology is a very well-defined epithelioid cell granuloma. Apart from this, there was nothing else on the slide. There was no necrosis, there was no inflammation, there were no atypical cells. Now, as soon as we give a diagnosis of granuloma in India, the first 3 differentials become tuberculosis. Nobody even thinks of any other granulomatous diseases, and that's exactly what happened to the patient. The patient was started on EKT with a possible second differential of sarcoid with an addition of steroids. So this patient received, I think, about 2 days of dexamethasone, and he happened to deteriorate. And that's when they decided to do a stereotactic brain biopsy. And that is all the fragments which I have shown you on the low magnification, that was all the tissue that was available for me to examine. It had 2 fragments. Fortunately, the fragments were very, very informative. So at this magnification, you can definitely appreciate that there are clusters of blue cells sitting there in pockets within those biopsy bits. And we are going to look at those blue cells a little more closely. And here, as you go higher, then you can definitely appreciate that those blue cells are around vessels. So a bit of that infiltrate is, of course, going into the brain parenchyma, but there is a very dense lymphoid infiltrate around the vessels. Now, whenever you see this kind of picture, then you want to rule out first thing is it vasculitis? Second thing is, are we looking at some form of meningoencephalitis? And third thing is, are those reactive infiltrates or tumoral infiltrates? So that is what is the concentration of pathology. This is again to take you through the higher power images of the sections, to show you the perivascular infiltrates and also to show you those cells which are going into the adjacent brain parenchyma. Now, unfortunately, about 50% of those biopsy bits were very necrotic, and you can see in the inside that there were a lot of histiocytes there, lot of apoptosis going on, and very little viable tissue available for examination. And I was wondering that perhaps that steroid intake of 2 days has generated this amount of necrosis and apoptosis within the tissue. Now, focusing on those infiltrates, particularly around the vessels in the areas where they were very dense, then herein you can see a kind of zonation pattern in those lymphoid cells. If you look at the black circle, then those lymphoid cells, as against those seen in the white circle, look little smaller. They look reactive. But if you go towards the periphery, the size of those cells are much bigger. They look very monomorphic. The nuclei are quite angry and hypochromatic, and there is hardly any cytoplasm. So now it's for me to decide whether it's a reactive T cell infiltrate or a clonal B cell infiltrate, and that's when we do the immunohistochemical markers. And this is a CD3. This is a marker for T cells, and to my dismay, a lot of those cells were actually reactive. So these were all reactive T cells in the perivascular region. Here you can see closely, but then even then you can see some cells which are not staining with CD3. If you focus on the images which are on the right side, then a good number of cells are not CD3. Then what are they? Are they B? And yes, they were of course B. So there was definite B cell population in this immunohistochemistry in the perivascular region. And mind you that so much of B cells are never reactive. Any tissue wherein you see more B cell proliferation in comparison to T cell proliferation is always a clonal B cell proliferation. Again, to show you that periphery, wherever the morphology of the cells were bigger, where they look more clonal, more hypochromatic, then you can see that those cells correspond to B cells. One more identifying feature in this image you can see is concentrating on the cells which are going in the brain parenchyma. So all those cells which are deviating away from the vessel into the brain are also B cells. So those are also clonal cells and not reactive cells, ruling out a possibility of a encephalitis or a vasculitis. Whereas the center part of the cells which are smaller and look like reactive cells were the T cells. Ki67 is a proliferation marker. As pathologists, we rely on this particular marker a lot. And here also, you can see that the Ki67 exactly correlates with the B cells. The peripheral cells and the cells which are going in the brain parenchyma are all lighting up with Ki67. So the true proliferating cells of this biopsy were the B cells which were clonal, and that helped me in giving a diagnosis of primary CNS B cell lymphoma. Of course, there were a lot of steroid-induced changes. This was not an easy diagnosis as it sounds here. There was a lot of brainstorming which went on in reading the slides and interpreting the immunohistochemistry. Patient further went ahead with getting a bone marrow done. The bone marrow was absolutely normal. The lymph nodes in the mediastinum were not very clinically significant, and that's why it was called as primary CNS B cell lymphoma. The patient went on to take 5 cycles of this RMVP regimen. He's absolutely fine, doing very, very well, as normal as any other human being can be. That's the follow-up MRI. The whole lesion has resolved. So the patient benefited with the help of the stereotactic biopsy with the immunohistochemistry. These slides actually were brought to me for second opinion, and the initial diagnosis given in the primary institute was vasculitis. So this was just to emphasize the role of stereotactic biopsy in picking up the right diagnosis amongst all the differentials that you were discussing just now, and of course, making a diagnosis of a post-treated lymphoma. One thing that the clinicians have to remember that even with the smallest possibility of a lymphoma, the steroid should always be held up. Even a single dose of a steroid can create havoc in the tissue. There have been a lot of reports wherein repeated biopsies, even surgical excisions, have been attempted in patients of lymphoma because of prior steroid administration. Unfortunately, that is not the story in this particular patient. We could give the diagnosis on the first biopsy, and it did help the patient. So that's all from my side. I would like to thank Dr. Zabin, who's our neurologist, for giving the clinical data. Thank you. Right.
Nodule in the chest and the parotid granuloma, how do you explain?
So as sir was saying, it's not uncommon to find a granuloma and a parotitis at that age. I think that is a dissociating feature. We don't give any credence to that granuloma anymore.
On and off parotids are reported as tiny enhancement. Just forget, that's a misleading finding. You rightly said, it's just bogus. I mean, this doesn't lead anywhere. Look at the MR. I mean, from where are we thinking of tuberculosis? Where? This pattern. I mean, we've been seeing tuberculosis for decades in this country. I mean, that pattern is so exorbitantly in favor of a lymphoma as the first diagnosis, as rightly sir said, and neurosarcoidosis because of the parotid. So I think what stays beneath everything is the patterns of presentation and the imaging. I think that is both the things were strongly favoring a very rapidly evolving disease in a 64-year-old gentleman.
Thank you.
I think you have everything favoring sarcoidosis, but then certain features were misleading, and gut feeling of everybody sitting here was in favor of lymphoma, and it turned out to be lymphoma. What could be the possible reason for worsening with steroids? Sir? Worsening with steroid.
No, all lymphoma need
worsening.
Not. Actually, there are a lot of patients which are lot of case reports are there refractory to steroids. Lymphomas refractory steroids. They respond very well to methotrexate, whatever regimen which she quoted. There are a lot of cases which are refractory to steroids. So, not that every lymphoma melts away with steroid.
Yes, that's also very true.
Any other comment or?
Thank you.
Okay.
Thank you, sir. Thank you.
So thank you all. Thank you.
Thank you.
Done well.
Thank you, sir.
So thank you so much, Dr. Madhusudhanan, Dr. Vijay Sardana for this excellent discussion, and Dr. Lakshmi Narasimhan